And for sure, we have to go for adequate ventilation. And don't forget to have a rotation of the compressor every 2 minutes, along with the pulse check, or even early if there is a fatigue for the persons who are involved in the compressions. And as we know, the teamwork always makes the dream work. And basically, the successful team is a group of many hands and one mind. And always the successful teams, they are not only having medical expertise and mastery of resuscitation skills, but they also demonstrate effective communication and team dynamics. So whenever you are joining with us and there is a sudden cardiac arrest, you will supposed to be the team leader till another member of ICU team will come and take over. So here I would like to emphasize your role as a team leader. As we all know, a team leader has good situational awareness and is a role model, and is exhibiting always the excellent behavior for the members of the team, is involved in the training and the coaching of the members, as well as he's a backup for his members, and is involved in organizing the team. It monitors the individual performances of the team member. It facilitates the understanding, and is having a situational awareness, means like paying attention for whatever is going on around, and is not only fixed to one problem. As a member of the team, we must respect their authority and be prepared to carry out the instructions by the leader. As we all know, the poor leadership, it will induce frustration, anxiety, and will have a negative impact on the team performance. And always, the role of the team leader is very important in the effective team dynamics. As we spoke about the team leader, which is focusing on comprehensive patient care, as a team member, we must focus on the individual task. So, as a member of the team, we must be very clear about our role assignments, and we should be ready to fulfill the roles and responsibilities. And our well practice in the resuscitation skills, our knowing about the algorithms, and for sure are committed to success as a member of the team. Once we are talking about the effective team dynamics, we are speaking about the operating forces within the team, which are involved in the successful initiation of the task. So, the team dynamics basically is composed of closed loop communication, clear messages, clear roles and responsibilities, knowing limitations, knowledge sharing, constructive interventions, re-evaluation, and summarizing, as well as mutual respect. As we all know, during the period of stress, the most important and essential part is the effective communication, like to listen, to understand, and to talk back. And if we are not having effective communication, it will lead to error and critical incidences which can occur. So once we talk about effective communication, we are talking about closed loop communication. Like a team leader wants to have a procedure done, so he will ask by naming the member of the team, and the member will reconfirm it by asking back, and will do the procedure and will acknowledge back to the team leader. This is known as closed loop communication. Why it is very important? Because it reduces the errors by removing the ambiguity. It allows for the questioning if the instructions are not heard clearly. So the closed loop communication is the cornerstone of the effective team dynamics. The importance of clear messages cannot be overlooked. As a team leader, we must deliver the messages in a controlled tone of voice, in a calm and direct manner, without yelling or shouting. As we all know, unclear communication, it will sure lead to delay in the treatment or to the medication errors. Similarly, the role of clear roles and responsibilities needs to be highlighted, because if the roles are not clear, then multiple members of the team, they will be ending up performing the same task more than one time and missing the essential task. It will lead to the freelancing of the team members. So it is the role of the team leader to assign clear roles and responsibilities to all the members of the team. In order to avoid inefficient team dynamics, the team leader must clearly delegate the task. If he is unsure of the responsibilities, he should not assign. And if, as a team leader, you want additional help and support from the members, we must communicate with the team members before we assign a special additional task with them. Here you can see like a minimum number of people which are required for a successful and effective team dynamics during the CPR is six, including the team leader. One is responsible for the airway and breathing, one is responsible for the compressions, and the other one responsible for defibrillation can cross change with the compressor to be the second compressor. One responsible for the vascular access along with the IV medications, and another is responsible for documentation. So, as we are talking about the pandemic of COVID 19, the recommendations by American Heart Association as well as Resuscitation Council of UK and the European Council is to minimize the number of people which are present at the time of arrest. Means to minimize the number which are needed for the patient care or essential for the task to be accomplished. And it can be as minimum as four. As you all know, the other most important components of team dynamics, I will not like to go more in the detail, except as I will still like to highlight the role of mutual respect. Always the good teams, they always maintain collegial relationships and they have mutual respect irrespective of their specific the degrees or the qualities or skills. The respect must always be maintained throughout. And briefing and debriefing is also very important. By the end of any CPR, the debriefing should be done by the team leader, and it helps in improving the future uh, performance of the team. Now we'll move towards the recommendations for the CPR, particularly in the patient who are suspected or confirmed COVID 19. As you all know, there were interim guidelines released for the healthcare worker during the COVID 19 outbreaks. For Resuscitation Council of UK, they had released their guidelines on 27th of March, which was followed by interim guidelines by American Heart Association also, and these are very precise guidelines. This slide, it looks busy, but we'll try to make it simple. If you will concentrate on the left side of the slide, you can see there are phases mentioned: phase 1, 2, and 3. So this algorithm is divided into three phases, which not only provides us the guideline for the management during arrest, but also gives us an idea about the recommended PPE which are required for each phase of CPR. Here, I would like to go back to the concept of aerosol generating procedure. As we all know, airway manipulations, airway interventions, and the chest compressions, these are the aerosol generating procedure. So they should be done when we are having proper PPE, which is the phase 3 of aerosol generating PPE, including the disposable gloves, gown, filtration face piece, which is respirator, which is fit test for you, and the disposable eye protection. So until unless you are not in the phase 3 or level 3 of aerosol generating PPE, you are not supposed to start the chest compression because these are aerosol generating. So if you see in the phase 1, there is basically discussions regarding further management, emergency management for the patient, treatment escalation, and decision. So here again, the most important point by all the associations, including American Heart Association and the RCUK, is the safety of the healthcare worker. So the most emphasis we have found in all the guidelines is about the early decisions regarding the patient management, treatment escalation, and the court status for the patient. Because the major aim is to avoid unprotected, unexpected cardiac arrest, decreasing the chances of exposure of healthcare worker to sudden cardiac arrest in these patients. So the safety of the healthcare worker is the priority. So if you see the patient is not for active CPR, is do not attempt CPR order is placed, it should be well communicated and well documented, and all the members of the team must be aware about it. And patient will enter into the algorithm for end of life care according to the institutional policy. But if the patient is active code, We'll assess for the unresponsiveness, like the patient not breathing normally. We'll activate for the resuscitation team and will state the COVID 19 status for the patient. Here again, it is very important to announce the query or confirm COVID 19. So the team which is coming for the rescue will be in appropriate level of PPE. Again, the safety of the healthcare worker is a priority. So we'll assess the rhythm. So rhythm assessment you can do with the level 2 of PPE, which is consisting of disposable gloves, gown, fluid resistant surgical mask, and disposable eye protection. As far as you are not initiating the chest compression, you can go with the assessment of the rhythm, check for the pulse. And if the patient is having a shockable rhythm, which are VF and the pulseless VT, you can give the shock for the patient and you can give up to 3 shocks till the team will arrive, and then you can start the CPR as per all the algorithms with the chest compression for 2 minutes followed by the pulse check. But in case if it is a non-shockable rhythm like PEA, asystole, then you have no option. Either go back and wear the appropriate level of PPE and to start the compressions, or wait for the help to arrive with the appropriate PPE to start with the chest compressions. And the rest of the things are the same like any algorithm for ACLS. Like you have to go for high quality chest compression, minimize interruption, consider reversible causes which are the H and the T's, and use the waveform capnography, establish the vascular access. And the special consideration which you can use are the ultrasound imaging, mechanical chest compressions in order to facilitate the transfer of the treatment if it is available, and coronary angiography, PCI, and extracorporeal CPR. It can also be considered depending on the availability in the unit. So, in order to summarize, I will still like to highlight the consideration for treatment escalation and resuscitation decision for all the inpatients should be done early, should be individualized, and should be documented well and communicated well. Once you recognize cardiac arrest, do not put your face near the patient face to listen or feel for breath. Only you will feel for the carotid pulse and call for the help, state the risk of COVID 19. And you will attach defibrillator and give the shock if indicated. As we know, early restoration of circulation, it may even negate the need for chest compression and ventilation. Here again, we have found there is a great emphasis on the defibrillation. It could be because of some reasons, because defibrillation is not an aerosol generating procedure, and you can still give the shock while you are in the level 2 of PPE. Second, the defibrillation, early defibrillation is a very important link in the chain of survival. And if the patient who is receiving the shock early within the first 5 minutes, more than 50 to 70% of the cases of sudden cardiac arrest, they survive if it is properly implemented. And for every minute there is a delay, there is a less chance, like 10% less chances of survival for these patients. So there is a more emphasis on early defibrillation. So you have to go for appropriate aerosol generating PPE, no chest compressions or airway interventions without full aerosol generating PPE, as I told before. If patient is not intubated, leave the face mask on the patient face for oxygen, and you can do only the compression, only CPR. And you have to restrict the number of the staff who are attending the CPR. Then you have to secure the airway by the most experienced and the competent member of the team. This is again very important in order to decrease the number of attempts, to decrease the aerosol generation during the intubation. And there are recommendations to use the video laryngoscopy if available. And once intubated and is able to be attached to the ventilator, try to maintain the closed circuit. We have to identify the reversible causes, which are the H and the T's. As you all know, hypovolemia, hypoxemia, hyperkalemia, acidosis, and hypothermia among the H's. And the T's like tension pneumothorax, cardiac tamponade, acute MI, massive PE, and toxins. Then dispose of or clean all the equipments which are used during the CPR. You have to remove your PPE safely, avoid self contamination, dispose of in the clinical waste bag, and don't forget hand hygiene, as my colleague Dr. Tasmia already she demonstrated in her lecture. And post resuscitation debrief is very, very important to improve the performance in the coming CPRs. So, if you know the general principles for resuscitation, there are three. Well, the most important is to reduce the provider exposure to COVID 19, then to prioritize oxygenation ventilation strategies with low aerosolization risk, and consider the appropriateness of starting and continuing the resuscitation. So, if you see how to reduce the exposure, as I told before, but here again, I will like to summarize for all of you. It is very important to save the frontliners and to avoid adding more to the victims. So, first of all, is appropriate PPE before entering the room. Limit the number of people who are essential. Always keep the door closed in order to prevent airborne contamination of adjacent indoors. Use of mechanical devices like Lucas, if available, and is appropriate. And to be proactive, like to bring those patients who are at the risk of sudden acute deterioration to the areas with the specific level of skills as well as appropriate level of PPE in order to avoid unprotected, unanticipated cardiac arrest for these patients. And the communication, the most important, the status of the COVID 19 patient to the new arrival in order to avoid their contamination. For oxygenation ventilation strategies, if patient is ventilated at the time of arrest, then leave the patient on mechanical ventilator, maintain the closed circuit, make sure it is HEPA filter is attached in order to reduce aerosolization. And you have to adjust ventilator settings, providing 100% FiO2 with the assist control mode, keeping tidal volume 6 ml per kg and the rate of 10 breaths per minute to avoid overventilation, and adjust the trigger to off. If the patient is not intubated, then you can proceed with the compression only CPR, and passive oxygenation can be done using the non-rebreather face mask. Manual ventilation with bag valve mask, it is very controversial, but if it is needed, it can be done by in accordance with the consultant who is leading the uh, code. So here again, the most important slide I will like to emphasize on the decision making. So the conversations and the treatment escalation planning, it must be prioritized, individualized, and it must be documented well and communicated well with all the members of the team. And early identification of suspected and confirmed COVID 19 patients who are at the risk of acute deterioration and sudden cardiac arrest, in order to prioritize them to bring to the areas with appropriate level of PPE and appropriate level of expertise for the management, again for the safety of the healthcare workers. So, in the pandemic, there is no emergency. The take home message will be the safety of the healthcare is a priority in any emergency situation, including the sudden cardiac arrest. Thank you. If you have any questions, I am available for answering.
Okay, thank you, Dr. Simon, for your presentation. I think still there is no any question until now in the chat room. I think it's clear for them. So thank you so much, Dr. Simon. So we'll move now for Dr. Asim waiting for principle of mechanical ventilators, which is very important, especially for non-ICU physicians to know, to understand the most important information, how is the essential of mechanical ventilators. Dr. Basim?
Can you hear me?
Yeah, yes. Yes, Dr. Basim, you can share your presentation.
Assalamu alaikum.
Assalamu alaikum.
Okay. Thank you, Dr. Ahmed, Dr. Saima. I will share in a second. Give me a second, Manish. Can you see this?
Yes, but you are in slide 16, number 16 now.
And this is not طيب ماشي.
We can just make a full view screen.
Yeah, I'm trying to.
Yeah, start from the beginning. Yes, F5, F5.
Okay. Are we clear now?
Yeah, it's okay now. Thank you.
Okay, Assalamu alaikum. I'm Bassem Hamid, ICU consultant. We will talk very briefly about the basics or essentials of mechanical ventilation. The aim of this talk is to introduce you to the concepts of mechanical ventilation and touch very briefly as to the indications, complications, modes, types, and the ending of mechanical ventilation. This is in no way intended to make you ready to use mechanical ventilation. This will happen, inshallah, hands-on when you are in ICU. But this is about the very concepts of mechanical ventilation. I'd like to start with a simple question about the defining feature or features of mechanical ventilation. Which of these very common associations, oxygen, pressure, definitive airway, or sedation, is a core part of mechanical ventilation that defines mechanical ventilation in your opinion? Uh, Please give me your answers to start the talk with. B, pressure. C, airway. Oxygen. A and C. C and D. D. Good. Any more thoughts? C, definitive airway. All of them. Okay, thank you. Let's think together about this. Oxygen is, in most cases, we apply more than room air oxygen on mechanical ventilation, but if a patient does not have any problem with oxygenation, the indication for mechanical ventilation is not oxygenation in him. We can and we do ventilate them on 21% oxygen. So this excludes A. Sedation neuromuscular blockade is very common, but in a patient who is very cooperative or on non-invasive mechanical ventilation, we do not sedate them. So this excludes D. Definitive airway is definitely needed in invasive mechanical ventilation, but in non-invasive mechanical ventilation, patients are ventilated under a fit mask, you know. So this leaves us with pressure. Pressure is the core and the essence of mechanical ventilation. There is no way you can ventilate a patient without pressure, and pressure is what differentiates between just applying oxygen through various ways of oxygen devices, oxygen delivery devices, and mechanical ventilation. So mechanical ventilation is pressure. And I wanted you to be clear about this because this is the exact opposite of physiology. During mechanical ventilation, the airways and the alveoli are always under positive pressure. Pressure is more during inspiration and less during expiration, but it is always positive. While in spontaneously breathing normal physiology, it is always under 0 to negative, yes, pressure. During inspiration, it's negative. During expiration, it's 0. So understanding this allows us to understand that there is an inherent harm during applying mechanical ventilation. The alveoli are not designed to operate under positive pressure, and applying positive pressure to them is essentially hard. We do it when it is necessary, but we need to understand this, and hence we need to understand that minimizing mechanical ventilation at all costs is always a goal. Another concept that should be clear is that mechanical ventilation is not a treatment, it's a support. So the mere goal of applying mechanical ventilation is keeping the patient alive until something else happens, like antibiotics work for community acquired pneumonia, Lasix work for pulmonary edema, spontaneous resolution happens in most cases of viral pneumonia. But mechanical ventilation does not per se treat the condition. And if we understand this, then we understand that the more is not the better in mechanical ventilation. It is not a dose-dependent intervention. So the least amount of mechanical ventilation you apply to keep the patient stable, the better. Understanding both concepts that I just said, we intensivists always need to minimize mechanical ventilation. What do we mean by minimize mechanical ventilation? Minimize all aspects of mechanical ventilation, starting with application in the first place. If it is not indicated, it shouldn't be applied. If it is not necessary, it shouldn't be applied. And then during the initial steps of mechanical ventilation, if a patient can be maintained on non-invasive mechanical ventilation, then he shouldn't be on invasive mechanical ventilation. And during the course of mechanical ventilation, we should apply the least oxygen, the least volume, and the least pressure we can to keep the patient well. And most importantly, the duration. Whenever the patient is ready to be liberated from mechanical ventilation, by weaning, he should be weaned. It should not be postponed because it only increases the harm. Now I want to very briefly discuss the relation of volume and pressure during mechanical ventilation. Obviously, the more volume, the more pressure. If you want to introduce to the lungs more volume, you have to bear more pressure. And if you generate a higher pressure upon the airways and lungs, then you will get more volume. But there are some details here. There are two different sources of the generation of pressure during mechanical ventilation. The pressure needed to overcome the airways, and this is in the diagram, the pipe or the stick. This includes the trachea, bronchi, bronchioles, and also includes during invasive mechanical ventilation, the endotracheal tube and the ventilator tubings. So there is a force needed for the air to flow through this long tube. And this force has to do with the flow, which is the volume per second you introduce. The higher the flow, the higher this pressure that you will generate. And it has to do with the resistance of these tubes. The longer the tubes, the higher the resistance and the higher the pressure. And the narrower the tubes, the higher the resistance, the higher the pressure. So these are the forces that dictate or generate that first type of pressure. This pressure has to do with the flow. So it only exists during the movement of the air from the ventilator to the alveoli, to the lung. While if you cease, the air ceases to move, this total equation is abolished because the flow will be zero in this situation. The other and more important source of that pressure is the pressure you need to fill up or distend the alveoli against their natural tendency to collapse, which is called the elasticity of the alveoli is their tendency to collapse when pressure is not applied on them. You need pressure to distend them. And this pressure has to do with the volume you need to introduce. So the higher the volume, the higher the pressure, and it has to do with the compliance of these alveoli. The compliance is the opposite of the elasticity. So the compliance means the ability of the lung or the alveoli to extend in response to the pressure. The more compliant the lung, the better. It means it can accommodate higher pressures without generating higher volume, sorry, without generating higher pressure. So the more the volume you want to introduce and the less the compliance of the patient, the higher the pressure you will have to bear. As we said, this is the more important pressure we focus on during mechanical ventilation because it has been proven that it correlates with the patient's outcomes in mechanical ventilation and especially in ARDS patients. You would always want to keep this, we call this the alveolar or the plateau pressure. So the less you keep it, the better for the patient's outcome. But the cutoff we intensivists agree on is 30. You don't want the plateau pressure to get past 30. This diagram explains how the first type of pressures is abolished if you stop the flow and you're only kept with the alveolar pressure. Now we will go through our talk more systematically, speaking about the starting with the indications of mechanical ventilation. Obviously, the first indication of mechanical ventilation is respiratory failure, whether type 1, like in pneumonia and pulmonary edema, or type 2, like in acute severe asthma, COPD exacerbation, brainstem lesions. So this is respiratory failure is obviously the major indication of mechanical ventilation. But also there are other indications, mostly for the protection of airway. So if a patient is unconscious, GCS is below 9. If there's direct trauma to the airways, if he has excessive secretions, excessive blood, like in hematemesis and epistaxis, if airway protection is compromised or in danger in any way, then the patient needs definitive airway. Definitive airway is endotracheal tube or tracheostomy tube. So in this situation, mechanical ventilation is not the main goal, it is the airway, but it is complementary to intubation. So you intubate the patient and connect to mechanical ventilation. The most frequent example of this is during general anesthesia. So you want anesthesia for the surgery, and for anesthesia, the patient loses his ability to protect airway, so he needs intubation. And if he's intubated, then he has to be on mechanical ventilation for this period. The last and least recognized indication of mechanical ventilation, although very important, is trying to balance oxygen delivery versus oxygen consumption. And this is most obvious during shock states. Shock state is by definition the loss of balance between oxygen delivery and oxygen consumption. Through mechanical ventilation, you can improve oxygen delivery by improving the oxygen saturation, and you can also decrease the oxygen consumption through application of sedation and plus minus neuromuscular blockade, and more importantly, by relieving the work of breathing that can mount up to 30% of the oxygen expenditure if the patient is tachypnic. So this is taken out of the patient and by the mechanical ventilation. So it decreases oxygen consumption and increases oxygen delivery, helping to restore the balance between both. If we are to try to start mechanical ventilation, we need, like anything, to set the goals. And obviously, the main two goals is maintaining oxygenation and controlling CO2. Maintaining oxygenation is mainly done through the adjustment of the FI2, which is the percentage of oxygen in inspired air. Increasing oxygen in FI2 increases oxygenation, and decreasing that decreases it. And also through the manipulation of the mean airway pressure. So the higher the pressure you apply to the airways during mechanical ventilation, the better the oxygenation. These are the two main tools we can use during mechanical ventilation to improve or change the oxygenation status of the patient. The other goal is controlling CO2, and this has to be to do with the minute ventilation. Minute ventilation is the total volume the patient is ventilated through a full minute. This is the product of multiplying the tidal volume with the rate. So if you increase the rate, the respiratory rate, or increase the tidal volume per breath, you increase the minute ventilation and you wash out the CO2. But other than maintaining oxygenation and controlling CO2, you should also aim at improving the patient's comfort, and this can be achieved through the careful selection of the mode that suits the patient, and with the usage of sedation and analgesia to make the patient comfort. Also minimizing harm, because we now understand that harm is always there when you start mechanical ventilation. So minimizing harm should be a goal of yours during mechanical ventilation. When you're starting mechanical ventilation, the first question is whether you will use non-invasive mechanical ventilation or invasive mechanical ventilation. Because we said we would always want to minimize mechanical ventilation, so we should always ask ourselves this question, because we prefer, if we can, ventilate a patient non-invasively. However, and unfortunately, most patients in ICU who are receiving mechanical ventilation will be under invasive mechanical ventilation, and this is because non-invasive mechanical ventilation is not suitable for most critically ill patients, and I will tell you why in a minute. But the clear, very well studied, evidence-based indications of non-invasive mechanical ventilation are cardiogenic pulmonary edema, COPD exacerbation, and obstructive sleep apnea. However, because invasiveness is something we always want to avoid in mechanical ventilation, we very frequently use non-invasive mechanical ventilation uh, in other indications other than these three. And to make it clearer, we could use non-invasive mechanical ventilation with caution whenever there's no contraindication to mechanical ventilation. So what are the contraindications of non-invasive? Unlike indications, there are many, and these are just some examples of the contraindications of non-invasive mechanical ventilation. So whenever a patient is not able to protect airway, and if he is not cooperative enough, I have questions, or what are these? I'm sorry, but I'm facing some difficulties. Okay. Okay. If a patient is not able to protect airway, the patient is not highly cooperative to receive non-invasive mechanical ventilation. If he is hemodynamically stable, if he has severe metabolic derangements like uremia, acute liver failure, acidosis. So all these are contraindications to non-invasive mechanical ventilations, excessive secretions, because you will not be able to suction the patient, facial trauma or burn. These are all contraindications to non-invasive. So if you have a look at these contraindications, and there are others, you will find that they exclude most of our patients in the ICU, unfortunately. Complications are also multiple, but they include pressure ulcers to the face during the tight application of the face mask. Claustrophobia is developed by some patients, abdominal distension, the possibility of aspiration and impaired nutrition are sometimes inevitably. But the most dangerous complication that we take very seriously in ICU is the masking of deterioration during the application of non-invasive mechanical ventilation. So as I just said, sometimes we apply non-invasive mechanical ventilation out of the desire to avoid invasiveness in indications other than these three clear indications. Like in COVID pneumonia, for example, we do that frequently because we have found that patients who are not intubated do better. But then this carries a risk that maybe it was not the best for the patients. So this is why when we apply non-invasive mechanical ventilation, we very carefully monitor the patients because sometimes they can deteriorate masked by the fact that they are on mechanical ventilation and they may have improving saturations or improving ABG while in fact they are deteriorating. If this happens, we only get delayed intubations and worse outcomes rather than improving them. If the patient is not for non-invasive mechanical ventilation, then we need to choose the mode of invasive mechanical ventilation. In a couple of minutes, I'll take you through the initial settings, but now I want to introduce you to the modes of invasive mechanical ventilation. There are many, but we will speak about the three most popular or most commonly used modes of invasive mechanical ventilation. And these are volume control, pressure control, and pressure support. Volume control and pressure control are both controlled modes, which means that every breath is dictated by the ventilator. I mean by dictated, I mean when it starts, when it ends, how much volume the patient gets, and how much time the inspiration takes are all dictated by the ventilator, while the pressure support is a spontaneously breathing or a spontaneous mode, where the patient can spontaneously breathe but supported by mechanical ventilation. And because it's spontaneous, then the patient decides the volume, the time, and the frequency himself. Obviously, you cannot start mechanical ventilation by spontaneously breathing mode, so you would always start with a controlled mode, volume or pressure. Volume controlled by name, it is volume cycled, which means that the inspiration ends after the target volume is delivered. And if you aim at a target volume, then you cannot target a certain pressure because the pressure is a product of the volume. So if we set our ventilator at delivering 500 milliliters per breath, this is the tidal volume, then we watch how much pressure does this generate. We can try to limit it, we monitor it, but we cannot control both volume and pressure. This is the most popular mode to be used in ICU. Pressure control is the opposite for volume control. Here you target a certain time under a certain pressure. So inspiration takes a certain time that you get to set on the ventilator, a certain time under certain pressure. And in this mode, the volume is just a product for the pressure. You monitor it, but you cannot control it. It is the total opposite. Both are mandatory, as we said, and there's no evidence-based difference between pressure control and volume control. There's no superiority in terms of patients' outcomes for pressure or volume control. So the choice of volume control or pressure control is most of the time made by personal or institutional policies and preferences. These are the most two popular controlled modes that you start mechanical ventilation with, and as the patient improve and you want to wean the patient, you need to switch to a spontaneous mode, and the most popular of which is the pressure support. In pressure support, the ventilator supports the breath of the patient, but he breathes on his own the same way he does when يعني normal, he's not ventilated. We call it flow cycle because the inspiration ends when the flow generated by the patient during inspiration decreases to a certain value, then the inspiration ends and expiration starts. All breaths are spontaneous, as I said, and this is the most popular weaning mode. So we are starting a patient on invasive mechanical ventilation. The first question is the mode. As we said, you always start with a controlled mode. So whether volume or pressure, it doesn't make a difference, but you cannot start with pressure support. Yes, the volume control and pressure control are equal in outcome. So this is the mode. Fi2 is the percentage of oxygen, and you would always start on 100%, and then you can decrease as you watch your patient. PEEP stands for the positive and expiratory pressure. This is the least pressure reached during the inspiratory cycle. And for many reasons, we have settled on not allowing the pressure to drop to zero during expiration or the end expiration during mechanical ventilation. So we use the PEEP, positive pressure, not zero. So, but you would usually start with a minimal PEEP. Minimal PEEP is widely agreed among intensivists to be 5. So you set at 5, and then you can change as your patient's demand. Then comes the volume. And here starts the difference between ARDS and non-ARDS patients. In ARDS patients, it is evidence-based that less pressures of 4 to 6 milliliters per kg of ideal body weight is better for the patient's. They directly correlate with the patient's outcomes. So if your patient has ARDS, you set at 4 to 6 milliliters per kg. And if he doesn't have ARDS, you can set up to 8 to 10 milliliters per kg. Now we said CO2 is controlled by the minute ventilation, and the minute ventilation is the volume multiplied by the rate. So the rate is dependent on your choice of the volume. So if you choose to start with a low tidal volume ventilation, then this means you need to increase the rate to compensate for the low volume. And if you are applying a higher volume, then you can decrease your rate. What is the ideal body weight? The ideal body weight, there is a long equation. It has to do with the gender and the height. Assist control. A/C means assist control. Controlled. You can call it controlled, not spontaneous. The mode has to be an assist control, which is volume controlled or pressure controlled, not a spontaneous breathing mode. Why difference between ARDS? Why? Because ARDS patients needs less volume to get better outcome. There's a huge study and a lot of substantial evidence that ventilating ARDS patients on lower tidal volumes improves their outcomes. So this is why if the patient has ARDS, you have to choose lower volumes. If he doesn't, you can give a bigger volume. This is why. Okay. So this is how you set the volume and rate. You do that. These are the basic settings of mechanical ventilation. After that, you monitor the patient in terms of saturation, the pressures on the ventilator, the development of something called the auto PEEP. You take an ABG, and then you can adjust accordingly. Adjust, which means if you find the patient is over oxygenated, you can decrease your FI2. If you find him under oxygenated, maybe you can increase your PEEP. If CO2 is too low or too high, you adjust the volume and rate to reach the better or the target CO2 you have chosen. Weaning. As we said, we start on a controlled mode, and then as the patient improves, you want to wean the patient because you want to minimize the time on mechanical ventilation. So I like to describe it in three steps. The first step is assuring that the initial cause for which you have ventilated the patient has improved. So you do not consider weaning unless this has happened. If you are intubated and ventilated the patient, for example, for community-acquired pneumonia, you do not even consider weaning unless community-acquired pneumonia has improved. And I'm not saying has resolved because this can take time, but at least it has to have improved before you consider weaning. Sorry. Another example, if the patient is ventilated because he is unable to protect airway because of profound coma, then you do not consider weaning until his GCS has improved. And likewise. So if this has happened, then step two takes place, which is reassuring that there are no contraindications for weaning. And contraindications for weaning are multiple, but they can be summarized in a way, yani, you can think of them that any severe condition that makes the patient very critical is a contraindication of weaning. So if the patient is hemodynamically unstable, if he has severe metabolic derangements, if he's unable to protect airway, if he requires high settings on mechanical ventilation, these are all contraindications to weaning. If there are no contraindications to weaning, then you can start what we call the spontaneous breathing trial. And this is when you switch your ventilator from a mandatory mode or a controlled mode to a spontaneous mode, most commonly CPAP with pressure support. This ideally should take between half an hour and 2 hours. You allow the patient to breathe spontaneously, supported by mechanical ventilation, and you monitor the patient during this period. If the patient maintains a good oxygenation, a good ABG, he doesn't get very distressed during this period, he's generating a good volume, he's not tachypnic, then this is the time you decide that the spontaneous breathing trial has succeeded and you can proceed for extubation. During this period of spontaneous breathing, if the patient develops distress, desaturation, and unacceptable ABG, hemodynamic instability, or anything, then you abort this trial and you go back to the controlled mode. I can see that there are many messages, but I'm anticipating that Dr. Koher is getting angry at me now. So, Malish, let me finish. I'll take 3 more minutes and then I'll answer the questions.
Okay. Take your time, Doctor.
Complications of mechanical ventilation. Sometimes complications occur because of the things related to the airway or to the sedation and analgesia. These are common associations, but these are not the complications of mechanical ventilation itself. So complications of mechanical ventilation are what we call ventilator-induced lung injury, which happens when mechanical ventilation itself causes a picture of ARDS, And there are categories of these that go beyond the scope of this talk, but we call them barotrauma, volutrauma, atelectotrauma, and biotrauma. I will not go to the details, but this is when pressure causes injury, volume causes injury, atelectasis, which is collapse of some of the alveoli, causes injury, or the release of inflammatory mediators causes injury. Infection is a very, very common and very dangerous complication of mechanical ventilation, and it is almost we haven't yet found a way to totally avoid it. We have bundles and many interventions to try to decrease it or minimize it, discover it early, treat it, but it is almost a part of mechanical ventilation that the longer you ventilate a patient invasively, the higher the chance they get ventilator-associated pneumonia, which um, largely increases the mortality rate for ventilated patients. Also, diaphragmatic atrophy is a relatively new concept in mechanical ventilation that we used to overlook before, and it was found to start happening very early on during mechanical ventilation. So taking the work of breathing out of the patient tends to cause, together with some medications and interventions we do, tends to cause thinning out of the diaphragm, and this complicates the process of weaning thereafter, because the patients get too weak to support themselves on mechanical ventilation. Thank you. These were my very quick notes about the essentials of mechanical ventilation. I'll try to find,
I think
yes,
there is a lot of question for you actually.
I will try to see them. What happened? The previous batches didn't have any questions. I'm
It's,
either getting better or getting worse. I do not
it's
know.
totally no, no, it's totally different. They are more care dispatch actually than the previous.
Okay. Can you repeat the respiratory rate point? Yes. There's something called the minute ventilation. Minute ventilation is the total amount of air in liters that the patient breathes during a full minute. So this is the respiratory rate, the volume, the tidal volume, which is the amount of air during a single breath multiplied by the rate. Let's say we are giving a tidal volume of 500 milliliters and our rate is 20. So the minute ventilation would be 10 liters per minute. Okay, so this is the minute ventilation. Now, if you are giving less tidal volume, if we agree that a specific patient needs 10 liters of minute ventilation, then if you decrease the volume, you have to increase the rate. If you increase the volume, you have to decrease the rate. When do you need to decrease the volume? In ARDS. When you can give higher volumes in non-ARDS, where the lungs are more compliant. I hope this answers it. The next is how to monitor autopsy. Meet me, meet me next Sunday, and we can do this together. This is way beyond the scope of this talk. It's a bit complicated, but for convenience, Yani, you just need to keep this concept in your mind and ask the respiratory therapist about it. In practice, we physicians do not monitor auto PEEP ourselves. We ask the respiratory therapist. But we need to keep this in mind whenever we are giving a high rate, because when we are giving a very high rate, then there's no enough time for expiration, and sometimes the patient retains some of the previous breath when the next breath is started. This is how auto PEEP happens. The patient does not exhale fully, and then the next breath comes. It's called breath staking. So if the patient has a narrowing of airway, or if we are applying a very high rate, this can happen. Just keep it in mind and ask the respiratory therapist. How to measure ventilator settings in bronchial asthma and COPD with high airway pressure. I think you are a disguised intensivist. These are not questions from the non-ICU. Uh, thank you. We do introduce a course for mechanical ventilation that focuses on this, but I think it will be a waste of everyone's time if we try to answer these questions now. So I really would be interested in discussing them later on.
Okay,
Thank
thank
you.
you, Qasim. Thank you so much for
Thanks a lot.
important lecture and very informative, actually, as usual.
Thanks a lot, Dr. Ahmed. Thanks, everyone.
Thank you. So now we will move to the next lecture and the last lecture. After this lecture, we will start the exam at 10:30. As per curriculum, it was scheduled at 10:30. The exam will be started. So please, everyone, to be stick with the time of the exam. And now we'll move to Dr. Walid Al-Atrabi. He will present the airway management, specifically in the COVID-19 patient. Dr. Walid, he's our senior, and especially in the airway. We are learning a lot from him, whatever we are doing a lot of airway procedures, but once he will explain to us, it's a different life, different enjoyment with his lecture. Dr. Walid, can you start?
Assalamu alaikum, Dr. Hail. Everyone. You always flatter me with these comments, and I hope I'm worthy of them. So I will start by sharing. Okay. All right. Okay. Here we go. So my summarized talk about airway management, and unfortunately, this used to be a practical and hands-on workshop, but we had to convert it into this oral talk only. So I will try to supplement it with some videos and some pictures to explain better what I intend to say. My name is Walid Al-Atrabi. I'm an ICU specialist with an anesthesia background. At the beginning, I don't own any of the videos in this presentation. They are downloaded from YouTube, and I'm only affiliated to King Saud Medical City. So when we discuss airway management, my only intention is to keep the pathway of air, either from the nostril or the mouth, to the beginning of the respiratory system, that's the larynx, to keep that pathway open, not obstructed. I'm not going to discuss anything related to what you are giving from the outside. If this pathway is obstructed, then there's no benefit, whatever you are giving from outside. And we're going to take it from the simple to the more complex, but I just want you to keep in mind that this is not the way we practice airway management in reality. We usually approach the patient with the golden standard or the most suitable method. We don't try the methods. We are just giving you here the enumeration so that you know all of them. So to start with, the simplest is using your hand. And this is a technique that we have all practiced in BLS. It's called jaw thrust. With jaw thrust, you should place your fingers, the index and the middle, at the bony angle of the lower jaw and thrust the mandible upwards. And I always emphasize here that put your fingers on the bone, not the soft tissue. If you put them on the soft tissue, you're actually obstructing the airway. Similarly, another technique also we saw in BLS, which is called head tilt chin lift. This time you use both your hands. With one hand, you are tilting the head, and with the other hand, again with the index and middle, on the bone of the lower mandible, you are lifting the chin upwards. This way, you can see here, the tongue is backward displaced, obstructing the airway. By doing this maneuver, you are removing the tongue away from the posterior pharyngeal wall and opening the airway. Now, there's no benefit of one method over the other, but just keep in mind that with head tilt, chin lift, there's an extension of the neck, and that's why it should be completely avoided if you have suspicion of cervical spine injury. And by default, we suspect cervical spine injury till otherwise proven in any trauma scenario. Next, we can use one of these, and these are oropharyngeal airways. And as you can see, the oropharyngeal airways come in different sizes that fit different patients. They are color coded. These colors code for the size that fits the patient. There are tables that you can read in books that tells you which color fits which patient, but we do not do that in reality. In reality, we follow a very simple technique to tell you roughly whether this oropharyngeal fits your patient or not. Put the oropharyngeal airway at level with the mouth or the teeth, and the tip should end at the angle of the lower mandible. The way we insert an oropharyngeal airway is a little bit tricky because we inserted, as you can see, the oropharyngeal has a C curvature similar to that of the normal anatomy of the airway. However, when we insert it in the other way around, in the opposite direction. We insert it, you can say, upwards instead of downwards, until we hit with the oropharyngeal the hard palate. Then we start to rotate it as we push in. And the reason for that is to avoid friction with the tongue. I'll show you this clip that demonstrates the method of insertion.
The angle of the patient's jaw. So I'm going to place the end of the OPA against the angle of the patient's jaw and have a look at the angle across where the patient's incisors are. So we're going for the level of the patient's incisors, which looks to be around about the right level for this size OPA and this patient. We then need to have a think about inserting the OPA. So to do that, we're going to invert it. So essentially turn it upside down and insert it into the patient's mouth against their hard palate, rotate it around, and then locate it into the airway, nicely into the oropharynx. So we're going to invert, insert, rotate, and locate. And that should give us a nice secure airway all the way through without the tongue flopping back against the soft palate at the back of the mouth.
So I hope this was clear for you. And the important thing I want to mention with the oropharyngeal airway is that if you hold it in your hand, it's made of hard plastic. And the reason for that is if the patient bites or closes his mouth or even has seizures, he cannot occlude it and thus cannot obstruct his airway. This is the advantage of it being made of hard plastic. Most importantly for me is an absolute contraindication of oropharyngeal airway, which is intact gag reflex. If your patient still has some level of consciousness and intact gag reflexes, do not think of the oropharyngeal airway. All you are going to do is that he's going to fight, cough, clench his teeth. You might even induce laryngeal spasm. So completely avoid it with intact gag reflexes. I'm not going to go into the details of advantages and disadvantages. Now, if the oropharyngeal airway is not that successful, you might think of the nasopharyngeal airway. Now, from the name, this is an airway that goes through the nose and ends into the pharynx. And being inserted through the nose away from the mouth, we don't need to make it of hard plastic, because even if the patient closes his mouth, he cannot occlude it or obstruct it. It's going above the hard palate through the nose. You can see also that it comes in different sizes that fits different patients. And again, we do not memorize any tables. You can use this rough method to tell you if it fits your patient or not. This time you start at the nose of the mouth, and the tip of the nasopharyngeal should end at the ear lobule. This is how a nasopharyngeal airway looks when it is in place. As you can see, going through the nose, above the hard and soft palate, ending in the pharynx. So let the patient close his mouth. He is not going to obstruct it. The problem with intact gag reflex of the oropharyngeal airway is completely overcome with the nasopharyngeal airway. Nasopharyngeals are very well tolerated even by conscious patients. But it has its own absolute contraindication. It is actually the contraindication of inserting anything through the nose. Let it be a nasopharyngeal, nasal intubation, nasogastric tube, and that is a fracture base of skull. So we're going to watch now how nasopharyngeals are being inserted.
We're going to face that towards the patient's septum. So in this case, if we go into the right nostril, facing the bevel towards the septum, and we're essentially just going to push it vertically down into the patient's airway, allowing it to follow the anatomical curve of the airway round to end up at the bottom of the nasopharynx. You can insert it into either nostril, and it's normally going to be into whichever nostril happens to be largest.
So I hope you noticed here that when we inserted the nasopharyngeal, we followed the normal anatomy curvature because we don't have the tongue as an obstacle in our way here. A little bit of advice here: lubricate the nasopharyngeal thoroughly. Although it is made of soft rubber, it's going through a narrower passage, which is the nasal cavity. So lubricate it thoroughly, because frequently we have trauma to the nasal cavities with insertion of nasopharyngeal airways. This picture shows you how very well tolerated a nasopharyngeal airway, even by a completely conscious patient. Actually, this RT inserted it for himself. So it is very well tolerated and overcomes the problem of intact gag reflex. But remember its own contraindication, which is fracture base of the skull. Now, if both are not successful, then we can move to another kind of airway. So this, what you can see here, is an airway. It's a little bit complex, yes, but still an airway. This is called laryngeal mask airway, or anesthesiologists like to call it LMA. The laryngeal mask airway is simply formed of this balloon, which is elliptical in shape. This is the part that faces or masks the larynx, and you get to inflate this balloon through this side port. Then you have the shaft, and then the your side of the LMA has what we call universal connector. This means it connects to an anesthesia machine, a ventilator, an ambo bag, anywhere in the whole world. And again, LMAs come in different sizes that fit different patients. And again, we don't have to memorize tables to figure out which LMA fits our patient, because this time the LMA itself will tell you. Any laryngeal mask airway you hold in your hand will have some information written on it, some very useful information. The first thing is this range. It says 30 to 50 kilograms, for example. This tells you that this LMA fits a patient in this range of body weight. The second thing is this, which is the volume of air you need to inject in the side port to create the seal, to fully inflate the elliptical shaped balloon. And the last thing is this line. This line goes all the way through the shaft of the LMA. And the purpose of this line is that after inserting the LMA, when you have this line aligned with the nasal septum or the upper incisors, this means that you are sure that the elliptical shaped balloon is midline and is facing the larynx. So it is creating the masking of the larynx and the seal around it. There are several techniques to insert an LMA, but I prefer to show or to talk about the classical method. In the classical method, you simply hold it as if you are holding a pen that you're going to write with. You insert it blindly into the patient's mouth, and you go as far as your hand allows you to go inside, using your index finger to slide the LMA against the hard palate. Of course, you will not go, you will not put all your hand inside, because your other 3 fingers will stop you. Once you reach your maximum limit that you can go in, you leave it, it's in place. You simply now need to inflate the elliptical shaped balloon. This is how an LMA looks when it is in place through the mouth, and the elliptical shaped balloon is now facing the larynx. Once you inflate it through the side port, it creates a seal around the larynx. Let me remind you that this seal, even if you inflate it with the correct volume, is not 100%, is not perfect. So there is still a chance of leakage, and leaked air is only going to go through to the esophagus, and this carries the chance or the risk of vomiting. And this is the contraindication of an LMA, full stomach. A patient with a full stomach, you should avoid the LMA. So now remember, oropharyngeal airway, contraindication is intact gag reflex, nasopharyngeal, fracture base of the skull, and laryngeal mask airway, the contraindication is a full stomach. Now watch this clip on the insertion. So I hope you noticed that before insertion, they recommend now to completely deflate the elliptical shaped balloon. When I was a resident being trained, they used to tell me, keep some air inside to avoid kinking and folding of the balloon. But now the recommendation is to completely deflate it. They lubricate the back side of the LMA, because this is the side that has friction with the hard palate as you go inside. So this should be thoroughly lubricated. Just because I mentioned that there are other techniques of insertion, I want to show you this interesting way of inserting it.
Seal blue. Place your index finger behind the patient cuff between the juncture of the inflation line and the main tube, and grasp the laryngeal blue securely. Place the tip of the laryngeal blue patient cuff just behind the patient's upper teeth against the hard palate. Massage some of the lubricating gel contained on the back of the patient cuff against the hard palate before advancing the laryngeal blue with a definitive force into the patient's airway. Allow the patient cuff and main tube to follow the curvature of the hard and then soft palate along the pharyngeal curve until positive resistance.
So this was just another way of insertion. As I told you, there are several techniques, but basically they are the same. Lubricate the backside, have it slide against the hard palate, using your index finger to push it against the hard palate, and this is again to avoid the obstacle of the tongue. This is a special type of the laryngeal mask airway, which is called intubating laryngeal mask. It's actually a laryngeal mask that is more curved. Once you insert it and you have good lung inflation, this means that you are actually masking or facing the larynx. You can insert an endotracheal tube inside it. And this is used usually with difficult intubations. Now, we're going to talk about the golden standard of airway management. If you noticed, all the methods that we described so far, our hands, oropharyngeal, nasopharyngeal, laryngeal mask airway, none of them actually gets inside the larynx. None of them goes into the trachea, and thus they are not secure 100%. The only device that goes inside the trachea is the endotracheal tube, and that's why it's the golden standard. Now, the structure of the endotracheal tube is simple. This is the patient's end. This one is the part that goes inside the larynx. And once you are inside the trachea and the larynx, you inflate this balloon, we call it the cuff, through this side port to create the seal inside the trachea. This is the shaft. And again, this is the universal connector at your side. An important piece of information is written on the endotracheal tube, which is this ID8 in this picture. This stands for internal diameter of 8 millimeters. And this is the number you hear intensivists or anesthesiologists talking about all the time. Give me a tube of 7, give me a tube of 6.5. They are talking about the internal diameter in millimeters. And in a minute, we'll see how this is important. Endotracheal tubes come into different sizes and different shapes that fits different patients. Some of them even have a modified structure like this one. Maybe it's not so clear in the picture. This tube has a coil of wire within the shaft. This prevents it from being obstructed if it is kinked. We use this endotracheal tube in surgeries where we are going to prone the patient. Pediatric tubes, the smaller sized ones, don't have a cuff because the cuff, when they are inflated with high pressure, they sometimes cause necrosis inside the trachea. Now we come to the issue of the size. The size of the endotracheal tube, now you know these numbers are internal diameter in millimeters. For an adult are not a big issue. In a male, I would use 7 up to 8, maybe even 8.5. In a female, I use a smaller one, 6.5 up to 7.5 maybe. The big issue is with the children and infants. You need to calculate it carefully. The formal or the most famous formula is this one, 1/3 of the age plus 3. So if you have a child of 6 years old, 1/3 of that is 2 plus 3 is 5. So you use an endotracheal tube of 5. This is a less formal and less famous formula, which is 1/4 of the age plus 4. But let me go back to the adults. It's not simply a simple number. Your choice of a size of an endotracheal tube differs according to why you are intubating the patient. For example, in the OR, an anesthesiologist intubating a patient knows that he's going to intubate for the duration of the surgery, 1 or 2 hours, then he's going to extubate. So he's going to choose the smallest suitable size. And this is to avoid irritation of the trachea and the larynx post-operatively. For us in the ICU, when we intubate a patient, we know that the tube is going to stay there for a while, for a few days, 7, maybe even 10 days. So we are going to choose the largest suitable size of a tube. This is to avoid blockage by dried secretions, to facilitate suctioning, and to avoid the ventilator giving you alarms of high peak airway pressures. So your choice of a tube depends on why you are intubating. This is how an endotracheal tube looks when it is in place. It has gone through the larynx into the trachea, and once the cuff is inflated, this creates a seal inside the trachea. So the gas you are giving cannot escape outside, and also anything coming to the side of the tube, like secretions or blood or even vomiting, cannot gain access into the lung. Now, to insert the tube into the larynx, you need to visualize this view. This is the larynx, actually. This part here is the epiglottis. These are the vocal cords, and in between them is the glottis, or sometimes they call it the glottic aperture. Beneath that is the trachea. So you need to see this view, and you need to insert the tube in between the vocal cords. Now, there's only one problem. there is no direct line of sight between your eyes and the vocal cords. And that is why we need to use some instrument to help us visualize this view. And this is classically the laryngoscope. The laryngoscope come into different shapes and sizes, and some with modifications, but typically they are of two main types. One with a curved blade we call Macintosh, and one with a straight blade we call Miller. Technically, there's a very important small technical difference in the way you use these two laryngoscopes. If you are using a laryngoscope with a curved blade, like the Macintosh, you need to insert the tip of the blade exactly in this point. This point is the common base of the tongue. This is the tongue here, and the epiglottis. And anatomically, this point is called vallicula. And the reason for that is that the vallicula has a very small ligament called hyoepiglottic ligament. Once you press that ligament with the tip of your blade, you are going to lift up the epiglottis to see or expose what is beneath it. And what is beneath it is the vocal cords. If you are using a straight blade like Miller, you actually put both the tongue and the epiglottis on top of the blade. So the blade actually goes here. We don't have Miller in our ICU. So we usually use the curved blade Macintosh, or if you're using a glidoscope, the glidoscope also has a curved blade. So you use the same method. Insert the tip in the vallicula. Then the classical laryngoscope got advanced and got improved into something like this, the glidoscope. Instead of the light bulb, they put a camera, and the camera displays the view on a monitor. This is video-assisted laryngoscope, where there's also a camera, and it displays on a small monitor on top of the handle. Now I'm going to show you an animated video of the proper way to use a glidoscope.
The GlideScope Video Laryngoscope, designed for first-pass success. A four-step technique to GlideScope video laryngoscopy combines direct vision of the patient with views on the GlideScope video monitor. Start by looking in the mouth to introduce the laryngoscope, at the screen to obtain the best glottic view, back in the mouth to introduce the endotracheal tube, and finally, at the screen to intubate. Begin step 1 with direct vision, looking directly into the patient's mouth. With the patient appropriately positioned and with the GlideScope video laryngoscope in your left hand, introduce the GlideScope into the midline of the oral pharynx. Gently advance the GlideScope until the tip of the laryngoscope is past the posterior portion of the tongue. Unlike conventional laryngoscopy, the GlideScope video laryngoscope is introduced midline. No lateral displacement of the tongue is required. Step 2 is performed while viewing the video monitor the entire time. With the GlideScope inserted, look to the monitor to identify the epiglottis. Then manipulate the scope to obtain the best glottic view. The glottic view is optimized by a combination of advancing or withdrawing the laryngoscope slightly, while increasing the tilt to seat the device in the vallecula or on the posterior surface of the epiglottis to obtain the best glottic view. When the GlideScope video laryngoscope is appropriately positioned, the glottic aperture is centered in the upper third of the video display. This optimal view in the display is achieved using minimal lift force, only 2 to 3 pounds. This provides a wider view and more working space for intubation, while the camera position further reduces the effect on the view from blood and secretions in the airway. The video image of the glottis when using the GlideScope video laryngoscope typically is a Cormack-Lehane Grade 1 or Grade 2 view. The user may be tempted to immediately insert the endotracheal tube and try to navigate it through the glottic aperture while continuously looking at the video screen. However, in step 3, it is very important that you look directly at the patient's open mouth and not at the video monitor, watching the passage of the endotracheal tube to help avoid potential injury to the tonsils or soft palate. The endotracheal tube, which in this case is shaped by a glide-right rigid stylet to complement the angle of the GlideScope video laryngoscope, is inserted under direct vision until the distal tip of the tube is very near the distal tip of the laryngoscope. This relationship is quickly and easily achieved, and only then should you return to looking at the video monitor. In step 4, focus on the video monitor as you advance the endotracheal tube. Returning your eyes to the video monitor gives you a view of the glottic aperture, and near it, the tip of the endotracheal tube. Sometimes a slight withdrawal of the GlideScope is required to reduce the viewing angle and allow the glottis to drop. The tube is then advanced by gradually withdrawing the stylet 5 centimeters as the tube moves forward. Viewing the entire insertion step on the video monitor allows you to quickly and gently rotate or angle the tube using the right hand to redirect as needed. To review, the 4 steps to successful GlideScope video laryngoscopy are: in the mouth, to introduce the laryngoscope; at the screen, to obtain the best glottic view; in the mouth, to introduce the endotracheal tube; and at the screen, to intubate. GlideScope.
So please remember the 4 steps. First, look at the mouth while you are inserting the GlideScope, then the screen to visualize the vocal cords, then back at the mouth to introduce the tube, then back at the screen to intubate. And every time you look at the mouth while you are introducing something, this is to avoid injury. Now I will show you a video clip on the anatomical landmarks that you actually see while you are intubating.
I'm going to place the GlideScope inside the patient. Now obviously you can kind of see there's the patient's nose, lips, right here, the teeth. Now as we go midline, you can see there's the hard palate right over here. Right behind the hard palate is the soft palate. And just below that, as we progress in, there's the uvula and the palatoglossal arches. Behind that, there's the pharynx. So this is the posterior wall of the oropharynx. And as we go a little bit deeper yet, switch the stylet around, here's the tongue, right there. That's the tongue. Go a little bit deeper, that's the tip of the epiglottis. And in between the base of the tongue and the epiglottis, that space in there is the vallecula. So if you're using a Macintosh blade, you want the Macintosh blade to wind up right inside here. And essentially when you're using the GlideScope, that's roughly the same spot you want the GlideScope tip to reach as well. But remember, unlike a Macintosh blade, with the GlideScope, you're going in midline. With the Macintosh blade, you're going in on the patient's right side and then scooping the tongue out of the way into the patient's left side so you can visualize the glottis. So if we progress a little bit further down yet, there you can really see the epiglottis. There. The blade tips in the vallecula. Now here's the structures of the larynx that we're looking for. Right over here, you'll see the vocal cords, one there, and the space in between here is your glottis. So when you're intubating the patient, what you want the endotracheal tube to do is to pass between the vocal cords when the vocal cords are open, right? And place the endotracheal tube down here in the trachea. So that's the trachea down here. You can kind of see with the intubation head those tracheal rings at the top. So that is the trachea. You don't want the endotracheal tube to go down here because this area here, that is the esophagus. Okay, so once you've got this visualization right over here, what you need to do is grab your endotracheal tube and then insert the endotracheal tube into the patient's airway like so. And you can kind of see where the cuff is against the cords right here. Further advance the tube another centimeter to 2 centimeters, and 2 centimeters is ideal, like so. And then when you've got the endotracheal tube in the proper position, of course, remove the stylet while maintaining the same position of the endotracheal tube. At that point in time, your laryngoscope can come out.
So I hope this was useful and demonstrated the landmarks while intubating. This is a fibro-optic laryngoscope, and again, this is flexible and is also used during difficult intubation. Now let us go a little bit quicker and discuss airway management with COVID. There is an algorithm that was developed to manage airway with COVID patients, since we are now in the COVID era. Let's break down this algorithm into pieces. The first thing, as you can see, it's called emergency rapid sequence intubation. So intubation of a COVID patient is considered a rapid sequence. Rapid sequence simply means that we do it quickly. And of course, you understand that the reason for that is to minimize the duration of exposure to the patient and the aerosols generated during the procedure. And the best thing to do when you want to do something very quickly is to plan it carefully. Take your time planning and arranging and preparing so that once you start the procedure, you do it very quick. So you can see here that the algorithm discusses about preparations of the patient himself with adequate pre-oxygenation and positioning, preparation of the team working themselves. They have to be in full protective gear, and they have to visually check each other for adequacy of their PPE, and then preparation of all the instruments and devices and medications that they might use during the intubation process. So adequate and proper preparation leads to a successful rapid sequence intubation. I'll show you a very short clip that gives you the formation of the team recommended for airway management of a COVID patient. This is very similar to the team formation in King Saud Medical City, which is 3 persons. So you saw that the team formation is 3 persons, and all the guidelines of COVID airway management recommend that the most experienced person with airway management handles the airway and 2 others assist him. This is a very slight different team formation where they have a 4th member. And you can see that this 4th member is not in PPE. He stays outside the room. His role is to help them if they need something that they didn't prepare, or to go and call for help if they need it. All the recommendations of the guidelines in airway management of COVID are intended for minimizing the duration and minimizing the exposure to aerosols generated by the patient. So for example, if you have to hold the mask like this for the COVID patient and pre-oxygenate him, it's done passively without ambu bagging or without positive pressure on the bag to avoid or to decrease aerosols generated. It has to be held tightly, and I will show you the recommended technique in a while. It is recommended to intubate the patient with a glidoscope, not the classical laryngoscope, so that you can stay away from the mouth and nose of the patient. Before connecting the ventilator to the tube after intubation, you must make sure that the cuff is completely inflated, because if you connect the ventilator before inflating the cuff, you are going to generate a lot of aerosols. If you have to switch between ventilators, or for example, from a ventilator to an ambu to transfer the patient, you must clamp the tube during inspiration. You allow the patient to have inspiration, and then you clamp the tube before you disconnect the ventilator, again to decrease aerosols generated. Perhaps you remember this picture from BLS also, when we used to say you hold the mask, tightly fitting it in a C and E fashion. The C is by the thumb and the index. You can see they are forming a C, and the E is by the other 3 fingers, more clear on this side. This is the E, and this is the C. Now, this is not the recommended way to fit the mask for a COVID patient. It is recommended to be a V-shaped fit. So these 2 thumbs form a V shape. And the reason for that is that this part of your fingers or your palm is much stronger than the fitting generated by the index and thumb. So remember, it is a V-shaped fitting. The other thing is it has to be 2 persons. One person is fitting the mask with both hands, and the other one is ambu bagging. Don't think of fitting the mask with one hand and ambu bagging with your other hand to minimize aerosols generated. Now let's continue with the algorithm. This is a very quick explanation about what we mean when we say rapid sequence. As I told you, simply it means be very quick about it. And as you can see, it's all about preparation. Preparation of the patient with monitoring, pre-oxygenation and position, preparation of your equipment, all the things that you think you might need, including drugs, and also prepare things you might need if you face a difficult intubation situation. These are the most commonly used induction agents, whether they are anesthetics and sedatives or neuromuscular blockers. Yes, it's very important to say here that neuromuscular blockage is also recommended when you intubate a COVID patient, because if you intubate a patient without muscle relaxants, he's going to cough and generate aerosols. But I think the details is beyond our talk. I found this interesting slide that summarizes what I've been saying. You can see this is the timeline for intubation of a COVID patient. As you can see, they started 10 minutes earlier to prepare, pre-oxygenate, give any medication they want, and paralyze the patient until they reach this point, which is the 0 point. So they took 10 minutes in preparation. But once you reach the 0 point, you need to accomplish the intubation within 30 to 45 seconds. And this summarizes the concept of rapid sequence intubation. I'm going to skip. Now back to our algorithm. We have done a good preparation in all aspects, and now we started the procedure. We now want to intubate the patient. If we successfully intubate the patient from the first time, that's very good and the procedure is done. But the problem is, what if we fail to attempt our first attempt? What if we fail to intubate the patient from the first attempt? Here we should ask ourselves a very important question. Are you still able to ventilate the patient despite that you couldn't intubate? Can you still provide him with adequate tidal volume? Can you still provide him with oxygen through the face mask, as we said, the 2 persons technique? If your answer is yes, then you can be slightly relaxed because you're not going to lose your patient. You can still ventilate him, but then you have to start thinking of your other available options. An option might be to have another attempt, but when you do try for the second time, you must optimize the situation. So, for example, use a stylet on the tube, use a larger blade, use a glidoscope if you haven't already used one. So you must optimize something in your second attempt. If you believe that you have done all this and it's not going to work, then you can go directly to plan C, which is your exit option, exit out of this critical situation, which is either to use a supraglottic device, that's the laryngeal mask airway, or you can obtain a surgical airway. And the recommendation here is a cricothyrotomy bougie assisted. And I will show you in a minute exactly what is that. But let's go back here when we failed our first attempt and asked ourselves, can we still maintain ventilation? If your answer is no, then you are in a very, very critical situation. Situation we call cannot intubate, cannot ventilate. So you cannot put the tube And at the same time, you cannot provide the patient with adequate tidal volume through the face mask or the ambu bag. This is very critical because you might lose the patient. Remember that your patient is already crashing and already with very limited reserves. So you need to act quickly. Either you consider one more attempt, again, as we said, with optimization of the conditions, or if you believe this is just going to be a waste of time, directly go to the bougie-assisted cricothyrotomy, the surgical airway. And I will show you this. This is the last video clip and the last slide on cricothyrotomy bougie-assisted. As you can see, it's done by military personnel because this is a very quick method used as an emergency, usually in wartime and in battlefields. Watch this.
Cric is indicated. You will start by preparing your equipment. Inflate the bulb with 10 cc's of air, looking for any leaks. Ensure you have your scalpel close by.
And prepare your bougie.
And then you'll use the head tilt chin lift method to visualize the larynx. From there, with your non-dominant hand, you'll place the larynx in between your thumb and first finger, and then palpate for the cricothyroid membrane. Once you have your site selected, you'll prep with either an alcohol wipe or iodine. And again, stabilizing, this can move quite a bit. So you need to apply a little bit of pressure and make sure that the head is nice and extended. From here, we'll make a vertical incision from the top of the cricothyroid membrane to the bottom. And so, as you apply enough pressure, that skin will naturally flay open, and then you'll be able to see the cricothyroid membrane. With that, you'll make a horizontal cut, and you will place your trach hook. And I'm using anterior pressure to visualize the trachea. You'll insert your bougie into the trachea. You'll receive tactile feedback to ensure placement, and you'll be able to feel the tracheal rings as you advance your bougie into the airway. Once the bougie is inserted, you'll remove your trach hook, and then slide the tube down the bougie into the airway. Once your tube is all the way inserted, you go ahead and remove your bougie and inflate your bulb with 10 cc's of air. So once your tube is in place and you've inflated the cuff, suction to ensure that the lumen is clear. You look at the tube, you confirm if you have misting on the tube or bilateral rise and fall of the chest if the patient is unresponsive. If you have someone to help you, you secure a BVM and use a stethoscope. You'll listen to the epigastric region as well as visualize bilateral rise and fall of the chest and listen to both lung fields. Once you've confirmed a compliant airway, you'll go ahead and secure the tube to the patient. And once you've secured your cric, you will reassess.
So I hope this was useful. And just quickly to summarize, the main issues about COVID patient airway management is to minimize the duration, minimize the aerosol generation, and to be very quick about it. Don't waste time. If you eventually think you're not succeeding in intubating, obtain a surgical airway. I hope this was enjoyable to you, and I apologize for exceeding my allowed time as usual. I am ready to take questions if there are any. Otherwise, you can proceed with your course as planned. Thank you very much.
Thank you, Dr. Walid. Thank you so much for your presentation. Still, there is no question until now.
So, as Dr. Basim said, either I'm getting better or worse.
No, for sure, they are better.
Thank you very much, and you can continue, Dr. Ahmed, as planned.
Okay.
Thank you very much.
Okay, thank you so much. So now we will move to the exam. I will send the link in the WhatsApp group. This link is open for 40 minutes to answer these questions. After that, we will close the link. So within minute, I will send it to the group. And thank you everybody for this commitment. Really appreciating this batch for the great effort and the attendance and following this program. Thank you. The exam now, it will be sent to the group. We will start it now. Okay, we send it here also. No problem.